of micro-research, which Bob will talk a little bit about, but it's not the focus of my talk. So we bring you greetings from Canada. It's afternoon for you, it's morning for us. We are located in Mi'kma'ki, the ancestral and unceded territories of the Mi'kmaq people here in Canada. We are committed to addressing the Truth and Reconciliation Commission's recommendations. We are all treaty people. So I thought I would start with making sure we're all on the same page with the topic I was given about global pandemics. And what's a pandemic? It's a large-scale outbreak of infectious diseases that can greatly increase morbidity and mortality over a wide geographic area and cause disruption significantly to economic, social, and political areas. Now, these are not new. COVID is in a long line. So I've just done a bit of a summary from the modern era, which you can find online at the link that I've given you there. So for 1999 to the mid-1920s, it was the 6th cholera pandemic, and it was in Russia, North Africa, and the Middle East, with waves continuing intermittently through the 1800s. 1918 to 1920 is the famous Spanish flu epidemic. It was global. It was said to have killed 50 million people. 1957 to 58, the Asian flu, that was H2N1, killed about 1 million people, especially the young, the elderly, and the pregnant. From 1961 onwards, we've had a persistent and ongoing cholera problem. It originated in Indonesia, and it spread to other parts of Asia, the Middle East, and in Africa. And for example, in Zimbabwe in 2008-9, it killed about 4,000. In Haiti and Yemen, there's about 500,000 have been affected, and it's now endemic in about 50 countries. In 1968 to 69, the Hong Kong flu, that was the H3N2 one, again in East and Southeast Asia, then to Australia, Europe, North America, onto Africa and South America. 1981, HIV and AIDS pandemic, global, more than 40 million deaths, and it's estimated that there are almost 40 million people living with HIV globally. In 2002 to 2003, there was the SARS pandemic. It was, again, a coronavirus. It emerged in China, spread to 20 countries and 4 continents, and it's killed about 8,000 people. Not nearly as powerful as COVID-19. 2009 to 2010, we had the H1N1 flu pandemic. Originated in pigs, again it was global, killed about somewhere estimated between 150,000 to almost 575,000. 85% of those deaths were in people under 65 years of age, which again is different than what we're seeing in COVID-19. More epidemics. In 2012, there was the MERS epidemic, which is the Mediterranean Eastern Respiratory Syndrome. It started in the Middle East, transmitted from humans to camels, and now it's now endemic in camels. The largest outbreak was in Saudi Arabia in 2014, and it's still going on. Its mortality rate is much less than with SARS. We're looking, it's much higher than with SARS. It was about 34% compared to around 10% with SARS. 2014 and to 16, we had Ebola swept West Africa. It spread beyond Guyana and Sierra Leone and Liberia. Again, 50% mortality rate, 11,000 dead. 2015 and 16, we had Zika. It spread across the Americas, particularly Latin America, with damage to the fetus when the mother was infected during pregnancy, with 5% of babies born with microcephaly. 2018 to 20, we had Ebola, returned again to DRC. Big risk here noted was in pregnant women with a 75% mortality rate. 2019 to 23, we've got COVID. It's everywhere. It's estimated to be more than 767 million cases and deaths around 7 million, although that's an underestimate. And then this past year, we've had Mpox, long endemic in parts of Africa, but in 2022, it started to spread to over 100 countries. There's only been about 140 deaths across 110 countries. More academics to come, and they're getting closer and closer and closer together, as that time chart showed you. This is just a map from 2015 to show you examples of emerging and re-emerging infectious diseases. This is huge, and it's getting worse. It is not small. So, what are the factors that increase a pandemic risk? Why do these happen, and what could be done? It's more animal to human transmission, since many of these pandemics have come from animals. And the combined risk of spread is, where's the spark for it to start? Where is a pandemic likely to arise? It is not surprising that so many of these pandemics have started in areas where there is close relationship with animals and with the boreal forests and other forests that are there, as well as markets where a lot of wild animals are brought in to be sold and then to be eaten. The spread risk, though, is how likely is it to diffuse broadly through the human population. So with our 3 COVID pandemics, SARS, MERS, and COVID-19, they were very different in their ability to spread and very different in the mortality rates. COVID-19 was so well spread human to human to human to human. That's why it ripped around the globe so quickly. But its mortality rate was only about 2.3%. In contrast, SARS mortality rate was closer to 10%, but it didn't spread that widely. And MERS mortality rate 34%, and again, human-to-human spread was not nearly as quick or rapid as it has been with COVID-19. The pandemic risk also matters with the mitigation strategies. How easily are we able to prevent and transmit and treat the infection and then decrease the transmission risk? What are the control measures that can keep this pandemic under control rapidly? So we need rapid recognition, need to be able to detect it quickly, and then we need to be able to use mitigation factors such as isolation, social distancing, hand washing, depending on what the vector is, before we've got pharmaceutical interventions or vaccines that can be used to prevent the problem. In 2005, the International Health Regulations, World Health Assembly passed the international and updated the International Health Regulations to compel all World Health Organization members, and Kenya is a member, to meet outbreak-specific standards for timely detection of potential pandemic organisms, reporting that you've got a problem, and response to addressing the pandemic problem. So, one of the issues there that's really important is how well can you detect and track what's going on. So the COVID impact in Africa has actually not been very clear, and there were a lot of speculation that Africa didn't have a problem with COVID. It's really that we lacked accurate information. It's a recent study from Zambia that by Gill that looked at all deaths in the central morgue in Lusaka from January to June 2021. They tested every single one of them with by PCR for COVID, and about 4 community deaths for each institutional death was the estimate, that they were underestimating this. But you can see through this mapping how many of these deaths were COVID positive and COVID negative, and how many based on the different age groups across the age spectrum. And you can see, in quotation marks, Lusaka didn't have any COVID. Oh, no. COVID was actually killing many, many people in Lusaka during that time, when Zambia didn't have a problem with COVID. So the African data is probably a big underestimation of what was going on with COVID pandemic throughout this whole time in the last couple of years. But before you stand back and say, oh, well, we didn't do very well, high-income countries didn't do very well either in tracking what was going on. We know we underestimated COVID because we've done water sampling to show that COVID was much, much, much more common in communities than the hospitalization rates would have indicated. And we also know, because we've looked at excess mortality above what was expected, and it was much higher than what you would have expected, that was attributable to the COVID deaths that were reported. So again, all of us globally have underestimated what COVID did because our surveillance and tracking were not as good as they needed to be. So what else did COVID teach us about pandemics? Many lessons learned. There was a paper that just came out in the Journal of Infectious Diseases last week that's pretty interesting because of the methodology that was used. There are many, many, many articles that looked at lessons learned from COVID. And it's not possible to even read them all because they're in the thousands. So Sullivan produced a paper online June 25th that he took machine learning to categorize all the papers that have been written about lessons learned. And there were over 1,200 articles in PubMed from 75 countries, although most of them came from the United States. There were not many articles that came from low or low middle income countries. Then he used a clustering algorithm to say what were the common themes that came out of these. And these are what I've listed on in the 1 to 7 notes there. But you need to understand that this summary by Sullivan about what we learned and what we need to do to globally go forward, it recognized, didn't pull up things that were not commonly said in all of these articles. So what the machine learning only brought out was things that everybody knew, but not the things that might have been valuable but were uncommon insights. So what were the 7 things that came out? Expanding the use of telehealth, adopting hospital operations procedures that were not done before, how we needed to avoid disruptions of other aspects of care, effectively conducting clinical research in the middle of a pandemic, more understanding of viral pathogenesis, need for improving public health response, and adapting medical education and other education areas. So what did COVID teach us about innovation and vaccines? Because I think that was one of the biggest lessons out of COVID. And it's not, full disclosure here, I'm a vaccinologist as well. That's the major area in infectious diseases I've worked in. So what are some of these lessons? Well, I'm going to share with you now some slides that Jerome Kim, who's the director of the IVI, which is the International Vaccine Institute in Seoul, Korea. It's mainly funded by the Korean government to help speed along vaccines. It's been going for decades and decades. And full disclosure here, I sit on their scientific advisory committee. So these are the lessons that we learned from COVID. Innovation at speed takes money. Okay? Lesson 1. The crisis spurred innovation, that's for sure. There was tons of attention on focusing to get us a vaccine. Lesson 2, funding realizes innovation. When you put the money where people are working really hard and are close to finding a result, you can get stuff coming out. And this just shows you the top recipients of COVID R&D funding. And I have to say, that they were predominantly in high-income countries, and some of them were from to the pharmaceutical company. We put a lot of money into getting this stuff out quickly. But as you can see, where did the money particularly come from, and where was the R&D? European Union, the United States, a small amount in the African Union, and you can see the rest that are along there. We can also scale up to billions of doses of vaccine. That was lesson number 3. We could not only develop a vaccine for against COVID-19, we could do the scale up for manufacturing. We really pumped it out. But, equity was really tough, as lesson 4 showed. Most of that vaccine early out went to high-income countries and rolled out for their programs. Most of it, very little of it went to Africa, and very little of it went to other low and low middle income countries in Europe as well. Big other lesson number 5 was vaccines don't save lives. It's vaccination that saves lives. And that's a very important thing for everyone to learn. We had vaccine, but we didn't necessarily get it into the people who needed to have it. And you can see the problems we've had here with this. So the 5 inequities and what we're going to have to do for the next pandemic, Well, we've got some problems here. Diagnostics. I already showed you the problem we had with surveillance and tracking, even in high-income countries. We need better, quicker diagnostics. We need better, quicker recognition of a pandemic as it's starting so we can try to be ahead of the scheme. We need R&D funding. We spent a lot of money in this pandemic. We really were able to roll out quickly. It did work. We saved lives with that early vaccine development and pressure to get it out. Manufacturing, we need more dispersed manufacturing. I'm going to talk a bit about that in a minute. Vaccine supply, COVAX, which was the worldwide initiative for COVID vaccine global access, didn't work nearly as well as what we had hoped. We need to fix that. The supply did not spread out around the world as we'd hoped. And vaccination, even when we had supply, we couldn't get it everywhere it needed, and our vaccine acceptance was not where we needed it to be. So we do know that COVID-19 vaccination saved lives. It saved many, many, many lives. It saved about 20 million lives. COVAX saved 7.4 million, but it could have saved 10.7 million if we'd been able to get it spread out better than what we had done. The human cost of inequity and missed targets, estimated that we had 8.2 million preventable deaths. Think of Lusaka, the data I just showed you. We probably could have prevented those deaths if we'd had immunization across the age spectrum, because it wasn't just in the old people that people were dying with COVID. So based on official COVID deaths, vaccination prevented 14.4 million deaths as of December 21. Lives saved increased to 19.8 million if we had used better estimates of excess mortality, with a global reduction of 63% in total deaths because of vaccine. But we didn't do as well as we could have. And in low-income countries, 3.3 million deaths could have been averted if COVAX had worked better and reached the 20% vaccination targets that had been set. And 8.2 million deaths could have been averted had the 40% target been met by the end of 2021. So we had a problem. So CEPI, which is the Coalition for Coalition for Epidemiology Preparedness Innovation, that was the 100 days to get us that vaccine for COVID-19. Well, we knew funding worked. It really did make a difference, but we need bigger funding even that we had. Regulatory efforts, we had to make sure it could get EUA approvals very quickly. That means we need the regulators to be well organized, ready to accept new data in a different way and expedite approval. Assessment, we need the laboratory and the clinical trials done. We need those diagnostic capabilities that I talked about for surveillance and to see what the impact is. We need platforms set up ahead of time for potential areas where vaccines could be used. We need to be able to push up production relatively quickly. And what we didn't do especially well, we need stakeholder and community engagement if we're going to get vaccines out to all the people that need it. And we need ethics preparation to make sure that we can expedite ethics for clinical trial approval. So we need to go faster and better. So what are the recommendations that can be done for the next epidemics, when and where they happen? It's not if, they are going to happen. We need regional research and development hubs, including in Africa. We need pre-negotiating finance and governance for research. We need that set up so they know the money can be coming in and they can get it out there where it's needed. We need ready-to-use clinical trials networks. We didn't have good clinical trials networks for countries that have HIV. So we didn't have data early on how effective a COVID vaccine would be in patients that hadn't even been diagnosed with HIV. In other words, their HIV was not controlled. We need ready to activate regional and sub-regional manufacturing capacity, and we need continuous assessment of the health needs. How can we expand our healthcare system to deal with whatever the epidemic is? And we need coordinated allocation of all the resources. We can do this better. One of the things that's really come out of the COVID-19 19 experience that I think is really important is many manufacturing projects have been announced in the last 2 years. A number of these are in Africa, including in Kenya, and much money has flowed to these countries to try to develop this capacity there. I think this is critical for the next pandemic, that vaccines can be manufactured in these countries and put out as quickly as they can be. So we also have to remember to think beyond our classic pandemics, that long list I gave you at the beginning for the last 100 years. We know that we're going to have a problem with antimicrobial resistance. That's not new microbes coming out. It's the same microbes we've got, but they're now resistant. So in 2019, WHO said this was one of the top 10 threats for global health. And it is on the 2023 WHO Global Research Agenda. Where are we with Miro? How can Miro help with all of this? Bob is going to talk about that in the next talk. But I think we need to think about how they could help pre-pandemic with pandemic monitoring and the pandemic response. Last slide for me. I just wanted to draw to people's attention. The website is there at the top of the slide, and I'll put it into the chat so you can take it from there. The University of Siena has a master's course in vaccinology that is sponsored by a number of international donors, some like IVI, as well as a number of companies, as well as a number of other organizations like WHO, like all different kinds of ones. You can apply from a low-income country. The whole thing is paid for you. So if you have faculty or graduate students who might be interested in a master's in vaccinology and drug development degree from the University of Siena, you should go to that website and apply. They select and train the best and most passionate. At minimum, you need a bachelor's degree, and from developing countries, as I said. And on that note, I will stop my presentation, and I hope Bob will then be able to go ahead with his.
Thank you, Professor Noni, for that insightful.
Great. Thanks, Noni. I'm here, and I'll try to set up my slides. Now, here it is. Here.
Professor Bob, our VC is on the link.
Are we still there?
Maybe we can allow him to say something. Professor Romanes.
From the new guidelines that we received.
Okay, I did.
Students' completion rate, that is the mandate guidelines from the ministry. Is that still the position?
Okay. I'm not sure. Is this a question for Noni that you're bringing up?
Student completion rate. Yes.
Yeah. Okay. Noni had probably the more difficult task in putting these things together. She had to review literature that existed. Fortunately, she has a great deal of information from her own experiences. My task is a little bit easier because what I'm going to try to do is predict what will be the needs for the future. And there's obviously no literature on that. Yeah, I wonder if everybody could close your microphones on this, so it won't be as distracting. But okay, let's move ahead on this. This is a session. We're tying it together. Noni has presented what has been learned from the past. I'll be presenting what I personally believe, and Noni and I have spoken about this, so I think we both have some agreement on this, but glean from our own personal experience about what will be needed in the future on the ground in places like Kenya, and it would apply in places like Canada as well. So this is the second part of this presentation. Health interventions for global pandemic innovation. What will Kenya need? I think we all in the developed world and in the developing world and in Kenya will have to keep our eye on the importance of sustainability. The SDGs have been set out. They encompass a far broader spectrum of needs and goals than the Millennium Development Goals. And fortunately, it fits very well with the developments in the world where we recognize that it's not only health, we recognize that health encompasses a broad spectrum of things. It's not only the medical needs that relate to the health of an individual or of a society. And the SDGs, I think, are a major step in trying to realize that. And what will Kenya need? What will we need here in Canada? A sense of all hands have to be on deck. Everybody will have something to contribute to it. The health of a nation is built up on a healthy society, a healthy agriculture and food production process, a good education process. So the healthcare of society is really just healthcare services, I should say, is just a small part of this pie that contributes to the general socio-economic, cultural, and environmental health of a nation. So, putting my thoughts together on this, Noni and I talked about this as well, and were three themes that we could identify, that I could identify, that would be important for boots on the ground in order to contemplate and deal with the next epidemic, the next pandemic, the next major threat to people in Kenya and in the developing world. One is the concept of One Health. Two is this concept of striving to be better. And three is the concept of leadership. And I'll tell you a little story on each of these as we move ahead, and I hope that you'll see how they all fit together. Okay, One Health. One Health is now a relatively new concept, but the idea that human health is really intertwined with animal health and with environmental health. We can't do one without the other. One of the lessons learned, I think, from the previous pandemics has been that the majority of them, and close to the vast majority of them, have a connection to zoonotic diseases and have a connection with the environment. COVID is a good example on that. It started in China, but it was probably of animal origin, and the contact of humans with wild animals and the transfer of viruses from animals to humans and mutations that made them made us more susceptible to it and more vulnerable to it. Ebola virus, a prime example of that, one that you're facing in Africa. There have been major strides done on that, but because there is an innate animal reservoir for that, it's clear that Ebola virus will continue to surface and affect humans as well. So the story I have, I had a few glitches with my own technical items here last night, and there was a thunderstorm and it might have affected this. But the story that I'm going to give you is one of my own personal experience. Listeria is a bacteria, Listeria monocytogenes. There was an outbreak in the Maritime Provinces in Canada in 1983, a long time ago. I was very much involved with it at the time as a pediatric infectious disease specialist. And I was called once during the night by the neonatologist, saying they had a newborn baby just born, had a very strange infection, clearly was septic. Could I come and help? Well, that sort of thing happened, and it was a clinical picture that fit with Listeria monocytogenes early onset infection, and that's what it turned out to be. We used to see that kind of an infection maybe once every couple of years, so that was filled it in for the next 2 years, I thought. But about a week later, there was another one, same picture. Clearly it was, and it turned out to be a bacterial sepsis relating to the birth process, acquired from the mother because the mother was ill at the same time. Both were very ill. The baby eventually died. The mother survived. So this cued me, there must be something going on in our communities around the maritime provinces. At that time, Listeria monocytogenes was not a notifiable disease. It was thought to be a random stroke of lightning that caused infection. But I went on the phone and called my colleagues in various cities out near us. Halifax is a city of about 500,000. Not a huge population, but there are other sister cities in our area of 100,000, 200,000 as well. And just about every person I contacted, they would say, oh, yes, as a matter of fact, we saw a case just a week ago. Oh, yes, there was somebody who had, I heard about that infection down the road in a small community just 2 weeks ago. And so clearly this was something wider spread than our own city. And when I called around to colleagues in farther areas, it turned out that none of them had seen any infections that were attributed to Listeria. So it turned out the outbreak eventually had in the neighborhood of 47 cases. It occurred over a 6-month period. The caseload was undoubtedly much higher than that because many of them were not detected. One of the prime features of infection in newborns is that it can cause midterm septic abortion or abortion, which might not be recognized as an infectious disease and might not have been reported or come to anyone's attention. But there were at least 22 adults who were affected and 25 infants, and 15 of those died. And the reason the picture below is of a cabbage is when the epidemiologists and the public health people finally got into it and investigated it. It turned out that this outbreak was attributed to cabbage, amazingly. What eventually became known is that a farmer in a province nearby was a sheep farmer, and he also grew cabbage to sell in the market. The cabbages were fertilized with sheep manure, and the cabbages were saved for a while. They store very easily and very well. Eventually they were taken to a manufacturer that converts them into coleslaw, which is just chopped up cabbage, and it was distributed throughout the 3 maritime provinces in Canada and not any further. Well, it turned out that one of the sheep in the farmer's sheep farm had Listeria infection, and it's well known that Listeria can cause a specific disease in sheep that's easily recognized. A veterinarian had made that diagnosis, but again, because it was not a reportable reportable in any way. It went under the screen. No one recognized it. The cabbages were contaminated with listeria. They were processed and distributed in the Maritimes. And people who had particular vulnerability to listeria ended up becoming infected. And for infants, the mortality rate is about 50%. This was turned out to be the first epidemiologically proven connection between the zoonotic aspects of Listeria monocytogenes and human infection. So lessons learned from that, there are certain people who are at particular risk to listeria: pregnant women, newborns of those pregnant women, elderly people, and people who have an immunocompromised immune system. The second lesson learned is that there are ways to avoid this, and appropriately cooking food, particularly for people who are in those vulnerable areas. But public health learned from this as well. Listeria is now a reportable disease, so that public health will become aware of it. And as well, the standards for food distribution and food monitoring have been incredibly increased over this time, so that there is now a zero tolerance in most countries in North America and in Europe for the Listeria monocytogenes in food. The result of that is listeria infections have virtually been eliminated in the developing world, and because of close monitoring and elimination of the foods that contribute to it. And this brings home, I think, to you the One Health aspect of our own health and how we're integrated and interact with animals, and how these things can be addressed if they're monitored and if actions are taken to that. The second aspect I'd put in here is striving to be better, asking questions that are pertinent to your own health system, to your own health of your communities and of your nation. Asking those questions that are important in your area, for your culture, and for your communities. Answering those questions, telling people about that, and bringing about change that will improve the health of your nation. Here's a story, two stories actually, that I hope will bring this point up. As Noni might have mentioned, we've been involved for the past 15 years in a program called Micro Research, which strives to train healthcare workers and other people in the community on how to do community-based research that will eventually help the community. Our premise is that local problems can best be identified by local people who know the culture and the context of those problems and can bring about the appropriate change. The local problems will not be solved by people from thousands of kilometers away. It's actually one story, but two parts to it, to illustrate that. The picture on the top, on the right, is a picture of Isha Grant. Isha was one of the first participants in one of our workshops. She is a physician, and her question that she wanted her team to work with her and address was, why do babies die in the first week of life in rural communities in Uganda? The statistics would say, and this was a question that Noni or I or people from Canada would not have thought would be pertinent, because we could look up the statistics, and they told us the infant mortality rate. But she pointed out that most of the births in Uganda at that time occurred in rural areas, in small communities, usually without any medical attendance, and usually they were not even registered for months afterwards. And that the situation in those communities, in those environments, were probably far different from the big cities, the hospitals, where the data was being collected. So she took on a very difficult task. She went into a community north of Kampala, gained the trust of the community leaders, gained the trust of women who had lost a baby in the previous year or two, and asked them to tell their story to her, and what were the situation, the conditions that related to the death of the baby. She did this using a World Health Organization and a document called an oral autopsy, which provides a series of questions which can provide good insight into what it is that might have caused the infant to have died. This is something that's used in situations like this, where there is poor records, poor documentation, and the oral history is the primary way of trying to collect information. Well, she collected her data, and the surprising aspect to her and to us when we read about it was that almost 50%, about 42% or so, of the babies who died in the first week of life, died relating to sepsis, and often there was could be traced to sepsis that originated in the umbilical stump. This was curious to all of us. She published this in a journal. She made others aware. She went back to the community, made them aware of her findings. Roughly at the same time, Florence, who was a nurse in Mbarara in the south of Uganda, conducted another study with her team. Her study was to identify what the traditional practices were around pregnancy and birth in rural communities in southwest Uganda. She did this in a very organized way, compared the practices with what would be considered health standards by World Health Organization, and categorized the practices into practices that actually would be beneficial for the pregnant woman and for the baby. Things like the fact that pregnant women would be the first to be served at the table at mealtime. That would be a positive one. Other practices were neutral, really wouldn't have any effect on the pregnant woman or the baby. But there were some practices that definitely could be detrimental both to either to the mother or to the pregnant baby. And one of those practices was how the umbilical cord was managed after the baby was born. And in rural areas, very often, their plan was to try to get rid of the umbilical cord, have it dry up as quickly as possible. So things were put on it, like soot from the fire, herbs and the like from the household. All of these are potential contaminants, and they are in contrast to the Ugandan and the World Health Organization recommendation, which is to wash the umbilical cord and with clear water, don't touch it, and let it dry and fall off with time. Well, Isha and Florence met one day at a micro-research forum, and they gave their short presentation, and kind of a light went on for both of them and for members of the audience. Aha! So now we have a likely source for the infection that Isha had identified, the contamination of the umbilical cord, because the majority of babies were not being treated in the manner recommended. That's the first part of the story. There's a long other part of the story, which I'll just summarize very quickly to say, they brought this to the attention of the Ministry of Health in Uganda. Eventually, the Ministry of Health of Uganda took action on it, and the recommendations were changed. The change was to apply a disinfectant, chlorhexidine, to the umbilical stump, and thereafter to let it fall off and dry the way it would normally. Out of that arose a small industry in Uganda of manufacturing these small tubes of chlorhexidine gel. They call them Umba gel, and the Umba gel tubes are now a component of the mama kits that are purchased by all pregnant women in Uganda in preparation for the birth of their baby. There are instructions of what to do, how to use it, etc. And it's widely used in Uganda, and I believe it's used in some parts of Kenya and Tanzania and other areas in East Africa. The outcome from this is that another study was done several years after Isha's initial study, and it found that neonatal deaths due to sepsis were no longer 40%. They were down to under 10%, about 7% in total. In fact, we can, I think, with validity, say thousands of babies have been saved each year due to the two small projects, questions that needed to be asked and were only thought of by people in the local environment, in the local situation, who had the confidence, the knowledge, the confidence of the others, and could have the effect, be effective in dealing with the Ministry of Health. Third aspect on this is leadership. The using One Health tools, investigating local problems, finding new knowledge, are only going to be effective if there is leadership. And here I'll tell you a story. I presume most of you will not know who Matthew Luquillo was, but I'll tell you his story. I think most people in Uganda will know. Matthew Luquillo was born in 1957 in Kitgum, Uganda. He was a member of the Acholi tribe, and he grew up in northeastern Uganda. His father died when he was about 12 years old, and the family, his mother and the siblings, were left rather impoverished and struggling over his early life. But Matthew was a brilliant student. He was first in his class in school, and in his elementary school graduation, he was first in virtually all of Uganda. He won scholarships to carry on with his education, scholarships to eventually go to medical school in Makerere University in Kampala. And he graduated from there. He went to, in his internship, to Gulu, to St. Mary's Catholic Missionary Hospital there. And within a few months of being there during his internship, the two founders of that hospital, an Italian doctor named Piero Corti, and a Canadian doctor, husband and wife, named Lucille Teasdale, recognized that leadership qualities that he had and his knowledge and skills. And they invited him to become, and they groomed him to become the new leader of their hospital. So he worked in Gulu at the St. Mary's Hospital for many years, actually, until he died. In 1989, he received a scholarship from University of Liverpool to study tropical diseases there. He took the program, earned a master's there, and was invited to stay on and he returned to St. Mary's Hospital in Gulu. Around that time, you may recall the Lord's Resistance Army was very active in northern Uganda, and they were conducted raids on various areas. In one of the raids, they abducted several of the nurses from the hospital. Matthew convinced the rebels that they should take him in place of the nurses. And he was taken by the rebels, agreed to that, and he was dragged through the forest and the woods of northern Uganda for several weeks before he escaped and eventually made it back to the hospital. This gives you some idea of the courage and commitment of him. But the real story for him that I really want to tell now is about the Ebola outbreak of 2000 and 2001. One of the chief centers of that was in Gulu. And it was recognized by Matthew, first recognized in Uganda by Matthew in Gulu. He was called one evening by the nurses because two student nurses had died of a mysterious illness, the features of which were bleeding and vomiting. He went to investigate this, and when he arrived, shortly after he arrived, a third student nurse had also died. He reviewed that night all of the records of those deaths and all unusual deaths over the previous few weeks in the hospital, and identified 17 people who had died with similar problems. He studied the literature that was available through the World Health Organization and from the Center for Disease Control, and came to the conclusion that he was very suspicious that these deaths were attributed to Ebola virus. He was the first person in Uganda to make that assumption. He told the members in the hospital, and he contacted the Ministry of Health in Uganda, and he began to organize the isolation practices to control this. With cohorting and isolation of patients in a separate building away from the main part of the hospital. This was so effective that by the time help eventually arrived from the World Health Organization, the person who was joining them, I can quote from what he wrote. He wrote, I thought people would be unwilling to work. I thought we would be facing a situation where patients were totally neglected and an isolation ward to which people wouldn't be able to come because they were just too ill and the staff were not willing to take the risk involved with it. But they had implemented the manual, a very specialized recipe. They were giving highly sophisticated care. It was absolutely remarkable what they were doing. The crisis with Ebola worsened, and more patients were brought to the center. More healthcare workers became involved with it as well. Eventually, the volunteer nurses and doctors in the unit were not able to cope with the deluge. Eventually, 12 of them had died because of Ebola themselves, these of the volunteers. To them, they were ready to mutiny, to do what other centers had done, to leave their hospital because of the fear of catching this deadly disease. He spoke to them passionately, and I'll quote from one of his presentations. It is our vocation to save life. It involves risk, but when we serve with love, that is when the risk does not matter so much. When we believe our mission is to save lives, we have got to do our work. The group were moved by this and other statements he made. He showed by his example as well. He wanted to walk the walk, live the talk, and he became one of the few physicians who was caring for patients on the ward 12 hours a day, as well as his other administrative duties. He was called tragically one night in the middle of the night for some urgent problem in the isolation floor. A patient had become unruly, and Matthew was called, quickly dressed, put on his protective items, but he forgot, perhaps in his drowsiness, waking up, perhaps because he was in such a hurry. He forgot the eyeglasses and the face guard on that. He caught Ebola, and he died within a week of this. The epidemiologists have credited Matthew credited him with saving hundreds, perhaps thousands of lives through his action and through his leadership. The New York Times described him as a fearless field commander at the center of a biological war that threatened everyone in the country. The American Medical Association named him as a role model for the world. The World Health Organization sponsors an annual Matthew Lukuya Memorial Lecture in Uganda. And Matthew lives on in the hearts and minds of Ugandans as a national hero. This is the kind of leadership that you and others in Kenya and in Uganda and East Africa are capable of. So the basic premise on this, lessons learned that can be applied to the future. One health is a cornerstone that we should be aware of. We should be working together with others through teamwork, collaboration, with others who are in the veterinary field or in agricultural fields, who are allied health, not just medicine and nursing, but other aspects of allied health, of people who are involved in high technology, because all of these can provide the tools that will work to confront the next problem. The second lesson is we all must be trying to ask the questions that are pertinent and important for the health of our people in our country and in our countryside. And the third lesson is we should all be willing and ready to shoulder the leadership that will be required when we're confronted with the next major pandemic or outbreak. This concludes my presentation. Thank you for listening. I don't know if there's going to be time for questions for Noni and myself.
Thank you, Professor Noni and Professor Bob. All the way from Canada. Thank you for that great presentation. So, members, participants, please, if there are any reactions for Professor Bob Botolushi and Noni, please, you can hear the reactions before we make our comments.
My apologies, but the feedback is so much I cannot understand. So could that be typed in the chat so that we could see it?
Okay, she is requesting that we can type on the chat. If there are any questions, those who are online, please, you can type on the chat. But before they can type, Professor, maybe I have a few things I can mention. First and foremost is that we are grateful for your participation in our conference. We are also happy that you have given us some information to our MSc or BSc student. Maybe you can clarify. Students who are willing to enroll for a degree in vaccinology at the University of Siena. You can give a clarification on that. Number two, the lessons learned post-COVID, very great lessons. The role of funding in vaccine development, the speed at which the vaccine were developed. We are also very happy for that information. However, you have also indicated the inadequacy of data of what happened post-COVID in Africa. Because people thought there were no deaths or people never died. We need to do some retrospective studies and maybe understand what happened. For Professor Robert, he has really emphasized on One Health. And for us who understand what One Health is whereby we link the disease to the population, animals, and what have you. So Professor Robert, thank you very much for being able to link the role of animals, environment, and disease, and even give us a case study of what is happening in Uganda and the new developments which are coming, of course, through micro-research program, which Meru University is part of it. We thank you for that. Again, for Professor Robert, he has given us the most important aspect of his presentation, lessons learned post-COVID. One, he has talked about teamwork, goals, vision, diversity, credibility, but above all, leadership, because I believe leadership becomes very critical in any disease intervention and in any prevention of it. So thank you very much. Maybe members, anything on our chat? Professor Noni?
For me, I think there's some things that Miro could contribute substantially that are needed. You listed one of them. Is COVID still killing people in the region around Miro? Because you may be like Lusaka, where COVID is there, but it's just not being detected at all. I think the other things that are globally needed in areas like Kenya, Uganda, pick your country in sub-Saharan Africa, what kind of platform for vaccine delivery is going to work for adults? Because most countries in sub-Saharan Africa, you've got infant immunization, and you know how that needs to be given. You've got immunization at schools with HPV, and you know how that needs to be given. But there's no standard program for adults. So it's not just COVID vaccines are one group of vaccines that need to be given, but there's other ones that need to be given as adults too. And there is no, so research needs to be done on how could you best do that in communities like that are where Miro is, as well as large urban centers like Nairobi. But even knowing in your own communities out there how you could do this best. What do people want? Where do they gather? How could you do this costly with the least cost and be most efficient? The other issue, yes, there's a lot of research on vaccine acceptance and the factors that block vaccine acceptance, the whole bit about how the vaccine comes, that it's injected, and on and on and on. But what has not been asked is, would it change how people would have accepted COVID vaccine if you'd been able to give it as a patch instead of an injection? And would that have made many more people that couldn't have come forward because, the issue about getting the vaccine to the district health centers, could that have been avoided because you don't need to have a nurse to put a patch on? It can be done much more simply. So research in that area, I think, would be very helpful as well. A big push to change and innovate how the vaccine delivery platforms that we have. Over. Just a couple of examples.
Good examples, Noni, and I think they all illustrate that these are local problems, local issues, and they can only be answered in the local environment by some of the people who are in the audience, perhaps, and who know the situation, who know the standards, the usual practices for vaccine delivery, healthcare delivery, and so on. And even something as basic as the epidemiology of infections, COVID, influenza, and so on, are probably quite different in a tropical area like Africa, like East Africa, whereas I would say 90% plus of the information about the epidemiology and the seasonality of influenza and COVID is all based on climates, temperate climates like Canada and the United States. So lots and lots of questions that only you in Kenya will be able to answer. Over.
Mic is not okay. Okay, Prof. For that insight, I think we've come to the end of our presentation. However, as you've said, these are local issues. When it comes to COVID-19, for example, we still have infections going on. However, the guidelines and strategies which are in place for continuing the vaccination of the population have not been insisted on. So there's likelihood of getting another wave of COVID outbreak if we don't take precautions in One Health. So as a matter of fact, every country, every nation will need to take its role in terms of how we manage post-COVID environment, in terms of delivery of vaccines, in terms of acceptance of the vaccines and other interventions associated with the post-COVID. And even maybe to mitigate the future pandemics. On that note, I wish to stop there, unless if you have the last one for the participant in our conference. Professor Noni, over. Robert, Professor Noni is muted. Maybe she can give her last.
Okay, if there are no other questions or comments for us, I want to thank you for inviting me and Noni to make this presentation. I hope it has reflected what your needs are. And I'll bid you from 10,000 kilometers away a very good
Thank you, Bob. Bye. We'll get in touch for the student you said can apply for the degrees. We'll get back to you through the email. Thank you very much. Bye. So, members, we have more presentation from our guest speaker from Mount Kenya University, Professor Victoria Wells Wilson, and I believe she's going to give us a good presentation. So members, let's be keen, and we have 3 or 4 presenters who have not done their presentation.
And that is what I'm doing.
Welcome, Professor Victoria Wells, to our conference. Can you hear us? Professor Victoria, we are waiting for you, please.
Hello?
Hello. Welcome to MUSTIC 2023, please. Prof, you can proceed, please. Go ahead with your presentation.
Hello?
Hello? Hello? Our mics, please. Go ahead, Prof. Prof, go ahead. Proceed, please. We can see your screen very well. You can go ahead. Wow.
Good morning. Good afternoon.
Good afternoon.
I just want to know, I think there's another conference starting in about 10 minutes. So should I go quickly through my presentation?
Yes, you can go ahead.
I don't know if anyone can hear me. There's a chat. Great, hi. I just want to know if I need to finish by 3:50 so that people can get to the next issue. Okay, well, I'll speak for a few minutes. I'm going to share my screen, and if you could tell me if you can see my screen, it should say testing for COVID-19, the good, the bad, and the ugly.
Well, the screen is all shared.
Use my lessons from working in HIV/AIDS epidemiology for the last 30 years to help you understand how the science behind testing, vaccination, and treatment has actually confused society in such a way that we've gone backwards, at least here in the United States, and I'm afraid in Kenya as well, and elsewhere in the world. Sorry, let's see, let me just see it. There we go. I have no conflicts of interest. I have no disclosures. I do want to acknowledge physicians and other professionals who have helped me on this presentation with the research. And I want to talk about the good, the practical application of CDC, the Centers for Disease Control and Prevention, algorithms in preventing COVID-19 transmission. Oh, and I do want to, I'm actually going to record this. I wonder. Okay, let's see. Hold on just a second. Well, not going to worry about it. Okay. The bad, there are limitations in science, and I'm going to go through those, and the ugly, how these limitations in science actually challenge public health. To begin with, we get guidelines and rules from all kinds of institutions. Here in the United States, we turn to the World Health Organization, the Centers for Disease Control and Prevention, CDC. Those are advisory bodies to be distinguished from regulatory bodies, which, again, here in Cincinnati, Ohio, USA, includes the Ohio Department of Health, our County Department of Health, our City Department of Health, and for workers, the Occupational Safety and Health Administration. Here's an example of the algorithms that we used from CDC to determine what to do depending on test results. And test results, I want to point out here at the top of my slide that we have an asymptomatic group and an asymptomatic group. And as you might know, with COVID-19, people could be positive and asymptomatic. And they could, if they weren't tested and they didn't know they had COVID-19, they could easily spread it to other places. symptomatic makes sense, but again, we don't want to treat for COVID if those symptoms are caused by other viruses, germs, or allergens, etc. And as you can see, it's quite a complicated algorithm because there were so many issues. And even though you won't be able to really follow this, the reason I'm showing it to you is just to show the extent of the complexities of testing and interpreting those tests for COVID-19. I'm going to skip a few things because we are short on time. Also, just to keep in mind that each institution is going to have unique priorities, and that's going to change how we react to positive tests. A negative test with a known exposure to COVID-19 is different from a negative test without a known exposure, and so on. Also, different institutions have different authorities. And so sometimes a school or a corporation or a county government could say you must do this, such as you must have a vaccine or you must be tested. In most situations, it's strongly recommended. And the question there is it enforced? Here are the symptoms that define COVID-19, and over the last 3 years during the pandemic, these symptoms have shifted slightly. Each COVID-19 variant has unique properties, both in terms of contagion, in terms of severity, in terms of symptomatology. So one variant may cause GI, gastrointestinal symptoms such as nausea, vomiting, and even diarrhea, and another causes conjunctivitis and nasal issues. We try to quantify which symptoms are most common and most illustrative of the disease as we define these are positive and these are negative. I'll be sharing my slides with the conference, and these are all wonderful links to places to get more information. But I wanted to talk about the tests themselves. And if you get a positive or a negative test, what is its predictive value? And I'm going to go over some definitions. The predictive value is the chances that a positive test is a true positive or a negative test is a true negative. And it's based on three variables: the sensitivity and specificity of the test itself, and what is the prevalence of the disease or the problem in the population. Just to remind you, sensitivity is the ability of a test to correctly identify positive specimens. Specificity is the ability of a test to correctly identify negative specimens. And so let me just give you an example of some of the tests that we've been using over the last 3 years to test for COVID-19. And I call attention to this column. Whoops, sorry. The column of sensitivity. At the beginning, the sensitivity was lower. The BINAX now, which was a test that could be used by people at home, had a fairly low sensitivity of 64 to 78%, but a very high specificity. As you can see, the take-home point is there's a wide range, even in the laboratory, where we're using these tests, where we have known COVID-19 cultures, do they test positive? We have known negative cultures, do the tests test negative? Let's just talk about prevalence for a second. Again, just as a review, that's the percentage of persons in a population with the disease in question. And of course, we don't know that as we begin a study or we begin testing a population, but we can estimate based on similar populations. I mentioned this is what the positive predictive value is, the probability that it's true, negative, the probability that a negative test is a true negative. And how do we calculate this? Here's a simple chart, and I will try to outline again that your sensitivity is A, which is this, over, this is a true case. True case is yes, and so therefore sensitivity is going to be all those that test positive who really are positive, and specificity is going to be all those who test negative who are true negatives, okay? But the tests are not perfect. And so a predictive value, which is over here, is the true positives divided by the true and false positives. Similarly, a negative predictive value are the true negatives over all the negatives that are shown by the test. And let's go through some numbers. Here's an example, and we're starting with a moderately sensitive test at 0.7, or that's 70%. Specificity is very good, 99%, and the prevalence is 10%. And again, this is a hypothetical situation where we know the true prevalence, and if we were to do this, these are the results we would get. Again, we have a 10% prevalence, which is represented here, that 10 of 100 people are really positive for COVID-19. That means 90 are negative. And then, how many were tested positive? Well, 70%, that's 7. And 3 tested negative, that's the 10. Similarly, we had 99% specificity. So almost all of these 90, in fact, tested negative with only one false negative. That converts to a positive predictive value of about 88%. Negative predictive value is even better at 97%. I'm going to give you a couple more examples. I'm going to skip a couple. No, let me go right to this one. The difference between my first example and the second example is that now I've lowered the specificity of a test to 0.9, that it's only 90% specific. And again, we have a low prevalence population. Why is it low? Well, maybe these are asymptomatic people. And so not many of them are actually going to be positive. Well, in a situation like this, again, we have the 7 out of 10 are positive, okay, are true positive. Excuse me. Yeah, 7 are true positives. Our specificity only picks up 81 of the 90 negatives, okay, because that's 90%, which is up here, of the 90. So doing the math, we'll see that if you have a positive test, which is 7, out of 16, your predictive value is only 0.44. That means fewer than half of the people who are testing positive actually have the disease. You're picking up 9 false positives right here, okay, because, excuse me, false negatives. Wrong. Let me say it again. These are negative people who have a positive test. So they are false positive people. There are 9 of them. There are only 7 true positives. And luckily, our negative predictive value is much better, which is 96%. That again 81 out of 84 tested negative, we only have 3 positives who snuck through. Those we would call false negatives. I have a few more examples, but I'm going to stop here just for a second to show that the epidemiologist or the public health worker who is required to respond to positive and negative tests has a difficult time if she's using a test with only 0.7, 70% sensitivity, 90% specificity, and 10% prevalence. Here are other examples where, again, now we've increased the specificity, we decreased the prevalence, we're doing better, that most of the positives are true positives, so we have 78%, and again, with a nice specificity of 99%, if we have a negative test, we can almost be guaranteed that it's a true negative. I wanted to show you this slide simply because now I've improved the sensitivity of the test. And if you go back to the slide where I showed you how sensitive and specific tests are, currently the tests we use today are closer to this level of sensitivity and specificity. So now let's look at a population like Cincinnati, where the prevalence is unlikely to be more than 5%. If you look at the numbers here, again, more people who are negative are testing positive than actually people who are positive. So if I'm at home doing my home test, I'm not really sure whether it's almost 50%, whether it's a true positive or a true negative. On the other hand, if I get a negative test, I can be quite sure that I'm safe, that I'm negative. And here are some more examples. All right. It's been complicated. The rules changed, the virus changed, the populations changed as we became more bombarded with information, and that's made it difficult. The science evolved. At the beginning of the epidemic, we were petrified of fomites. If we touched a cup that had someone else had touched, we would get it. Well, no, we learned later it's airborne, and that's why masking was so important. Young people recover from this disease, praise the Lord. But older folks, like myself, we're very vulnerable. The tests have changed, vaccines have changed, treatment has changed. So I want to conclude with the ugly. The fact that these changing dynamics have really challenged public health. Let me start with something from HIV epidemiology, and that's the importance of stigma. And you're well aware of that, living in planet Earth over the last 45 years of knowledge about HIV/AIDS. What happens with stigma? It leads to lack of transparency, leads to misinformation, leads to fear, people withdraw, and that increases stigma. Another cycle is the confusion. One organization says A, another organization says B, and then my favorite news outlet says C. It becomes chaotic. Again, leads to misinformation being perpetuated. People have alternate realities depending on sources of information, polarization, and more confusion. Fear is another problem related to any pandemic, and sure enough, that leads to irrational thinking, misinformation, more alternate realities, polarization, and more fear. I've shortened my talk a little, and I assume we won't have time for questions because we're late, but I'm happy to take them if that's possible. And there's my email. I'm happy to be contacted for more information or to get a copy of this presentation along with the background. Thank you very much.
Thank you, Professor Victoria, from University of Cincinnati, USA. We thank you for that presentation. Because of time, people can contact you through the link and the email you have sent there. I hope I'll get it. Somebody can write it for us, please. Our rapporteurs can write it for us. And we appreciate you for gracing our MUSTIC 2023. We will wish to meet you next time, or when you visit to Kenya. Welcome to Meru University of Science and Technology. Thank you very much.
Great. I hope to attend MUSTIC 2024. Thank you.
We are welcoming you back to MUSTIC 2024, and we are going to send an appreciation note. Thank you very much. Members, we have 4 presenters. I hope they are in. That is presenter Mary Joy Kagendo. You are present? Mary Joy Kagendo with the presentation on adolescent girls, a case study of Chuka Sub-County, Tharaka-Nithi. We have a determinant of uptake of utilization of contraceptives among undergraduate students. That one is present. We have a presenter by the name Work-Related Musculoskeletal Diseases and its Associated Factors. Are those presenters in, please? Okay, if they are not in, let's get the presenter for determinant and utilization of contraceptives among undergraduate students. Prof, I request you come here. I'm taking over. I'm presenting. The presentation is not here. So I use my laptop. And I send it. The symbols are not.
Lilian. Do we have Desta Aftu? Desta Aftu? You know, the presenter, the final or the last presenter. Is he around? Okay.
evening. Good evening.
Evening.
I'm delighted to be here this evening. I want to take you through this project, which was carried in Meru University of Science and Technology about the student, undergraduate student. Our presentation captured the area of contraceptives. What are the contraceptives? The contraceptives we are thinking about, or we were thinking about, is the ones which are in the market. The youth usually makes around half or more than half of our total population. But when the discussion for contraceptives arise, they are never put in the picture in our programmatic agenda in this country. So, what is the challenge? Contraceptive use has been declared as one of the fundamental human rights in very many nations, and it should be prioritized for that matter. It has been captured in our policy framework, MOH 2000, and contraceptives has a lot of benefits among the youth if they are well used, because they help them to make choices. Now, one of the choices is that they can help them to have what we call unintended pregnancies. We don't call them unwanted pregnancy, we call them unintended pregnancy, because the objective of them is not to make babies, but to maybe enjoy themselves. So, we know majority of the youth are sexually active, and for them to realize the aspect of safe sex and in a responsible manner, contraceptives becomes one of the key aspects of their life. So Kenya has been known to be the highest, be able to meet the highest regard in terms of targets for contraceptives. Kenya is doing very well. And this doesn't reflect among the youth. So family planning services are very key. Because our study was evaluating the haptic and the utilization of these services, we're asking ourselves, why are we not having the good haptic? So contraceptive services, for them to be accessible, for them to be available, they need to have an holistic approach in terms of where they're delivered, who is delivering them, and the information to the consumers of these services. When it comes to couples or families or people who are in the family settings, it becomes very easy in terms of accessing these services. Actually, out of 13 counties in Kenya have been allowed to use CHWs and CHVs to deliver family planning services. Unlike other counties where there is good infrastructure in terms of family planning services. Meru County has a contraceptive availability rate of 43%, and which means 77% of the people are not accessing these services. Meru University falls in this region, and with a population of over 10,000, 11,000 students, then we really believe there's a gap and something must be done. So Meru County has a child marriage level of 24.6%, and a marriage below 20 years, or those who are getting married when they are less than 20 years, they are about 71.6%. This is according to Kirigia and Moriah 2019 research. Data from the universities indicate that the uptake stands at 34%, and you can see, even in Kenya we have 32 or 34 universities, 35 universities. You can see where we start. So the proportion of facilities with youth-friendly services in our country also are very few, or they are very minimal. What do we refer to as youth-friendly services? These services include counseling, adolescent counseling, HIV counseling, and among other things, reproductive health counseling. So how many hospitals are having those services in Meru County and in Kenya by extension? There are very few. So the main objective of this baseline survey was to investigate factors influencing uptake and the utilization of contraceptive services among the undergraduate students aged 18 to 27 years in Meru University of Science and Technology. The design was a descriptive cross-sectional survey, and it took place between the months of June 2022 and December 2022. The methodology was a descriptive cross-sectional survey whereby around 333 students were sampled and selected randomly from the various schools in the university. That is Meru University of Science and Technology. What were the results? So we did a baseline survey. The uptake and the utilization by undergraduate students was associated with age, with the highest, with ages between 22 years being the highest at 25%. The return rate was over 100%. The response was good. That, as the figures indicate there, the School of Education, we captured around 19.2%, School of Business, 18.9%, Pure and Applied Science, 15%, Computing, Health Sciences, and Engineering. And the lowest was School of Nursing at 5%. Agriculture was at 2%, it was the lowest. The graph there indicates the percentages per school, and you can see, and the ages of the students who are interviewed. Utilization and uptake by religious category. Muslims were noted, other religious groups were noted to be lowest in terms of uptake. And the most astonishing aspect is that people believe that most of Muslims don't use family planning services. But we realize even the Muslims have noted the importance of contraceptives. Because contraceptives help a lot, and I think that's why the data is like that. The study also reviewed 57% of the student population were not using. That's majority actually, which means 42.9% were utilizing the commonest available contraceptives, which is the condoms, unlike other contraceptives. The utilization of services was approximately 42%, and the number indicates low utilization of these services. Utilization level was relatively low compared to the set target by the Ministry of Health. The results did not portray the actual condition of utilization of family planning services in Kenya universities. So this cannot be representative. We need to do a big study so that we can postulate what is happening in other universities in Kenya. The last bullet indicates that participant attitude was influenced contraceptives utilization and uptake, with the respondent perceptions and discussion of contraceptives with partners standing at 68%, 0.82%. There was a positive feedback. 25% never discussed about contraceptives with their partners because they found it very embarrassing. While contraceptive responsibility was at 53.2% for both the gender. 28.2% of the young ladies believed it needs to be discussed, and 18.2% of gentlemen believed it was their responsibility to discuss contraceptives. That was a good indicator, especially where men are concerned. So utilization of contraceptive services was influenced by Meru University Healthcare System factors, with the point of issue being shown by majority of respondents, that is at 68.0% as the reason for not seeking the contraceptives. 22% had fear of discrimination, and 10% of the students indicated that most health facility did not have privacy for them to request for the services. Conclusion, Meru's indicated high levels of uptake at 51%, and the females indicated, and their counterpart was at 49%. The reason for this was because of the only available method of contraceptive, that is the condoms. This was the one which was most available. Majority of the students also did not utilize the services, while females utilized the contraceptives at that percentage. Urgent adoption of a holistic approach in the reproductive health care system, strengthening in Meru University is key, and the integration of the delivery of this system on the use of contraceptives is very important to support the mainstream reproductive health system. Adoption of better contraceptive management practices, planning strategies, and the involvement of the youth or the students in this is very important. Recommendations. Students for female gender need reproductive health education because unlike other settings, women are at the forefront in the uptake of the contraceptives, but in Meru University it was the other way around. Although there was bias, there was a lot of bias because of the type of the contraceptive which was found in the unit. There was low level of utilization, was associated with lack of inconsistent supply of these contraceptives, especially the condoms. They complained about that. Student attitude on the contraceptives was low, hence more emphasis on need to be directed on educating the students on the need to change their attitude towards the contraceptives. Meru University Health Facility need to expand its reproductive health scope and offer various types of contraceptives and services for its clients. Improvement of communication to the core clientele to reduce discrimination faced by students as they seek for the services. Development of institutional tailored reproductive health program. The university needs to link with the stakeholders, that is the Ministry of Health, the County Ministry of Health, so that we can strengthen the reproductive health program at the university level. Because this is one of the group which is not captured under programmatic levels of the Ministry of Health, because the people who are handled there is youth out of school and the young couples. But for the youth in school, they are not referred to as either parent or anything. So in the family planning program, they don't exist. Whereas we know they are very sexually active. Support resource allocation to bridge the inadequate implementation of contraceptive services program for effective and ultimate delivery of quality reproductive health care among the university students. Thank you. We acknowledge the School of Health Sciences, the Department of Clinical Medicine, and the Meru University at large.
Thank you very much, Dr. Kubai, for the exciting presentation that you've already shared with us. And we want to appreciate Dr. Kubai for the good presentation. And now let me open the floor for any comments or questions from the audience. Yes, there is.
Thank you so much for the presentation. However, there are two inconsistencies I noticed. The first one, you say that contraceptive availability is at 43%, and you said that the unavailability is 77%. I would like that you clarify, because that doesn't tally up. The total availability should be 100%. The second one, you say that 57.1% of males do not use contraceptives, and then you went ahead to say for 2.9% of females utilize contraceptives. I think the two statements do not agree. One is utilizing, and the other one is not utilizing. So I don't know if you meant 57.1% of males do not utilize, while 42.9% utilize. So I did not get that part clearly. Thank you.
Yes.
Thank you very much for such a nice presentation, Dr. I was just seeking clarification about recruitment or identification of the participants, especially the chart that was showing contraceptive use by religious beliefs. So I know we don't have a large population of the Muslims here, whereas we have quite a number of Christians. Were they equal, or what criteria was used to calculate the percentages? Was it a fraction of the total, or what was done to get that? And also for the school, some schools are large, like the School of Education, whereas like us in engineering or the nursing, we are not many. How was it done to ensure uniformity or inclusivity for all the schools involved?
Okay, I think in addition to that, Kubai, those were good results. However, there is the issue of one, you say contraceptive utilization is low in relevance to your data, but that must depend on the type of the contraceptive that you are discussing. I also want to echo the confusion that is being noted in terms of the utilization, where you say males had 51% utilization of contraceptives. At the same time, you say those who did not utilize contraceptives were 57.1%, vis-a-vis for the female 49%, and 42% without utilizing contraceptive. The numbers do not add in. And I also wanted to echo the concern in terms of the demographics. What was the sex composition of your study population?
Okay, thank you very much for those concerns. First of all, we are talking of the males who are utilizing, the availability of these contraceptives was condoms, and that was the most available contraceptives. So for females, they talked about the use of condom, which stood at that level. When you talk to the student, remember also the issues of confidentiality. So you don't go exploring so much. As for females, when you ask them about the usage of condom, they will tell you yes. When you ask them it's male or female, then there was also not getting clear information. So because of confidentiality and not losing people to the study, we didn't do a lot of interrogation. That's why we said this was a baseline for more and further study. The other question was about the gender, how we did the sampling. Actually, our sampling was very simple, so we did simple random sampling across the schools, and the only way of identifying that was asking the student which school they come from. Until you get the number which you wanted, then you close the interview. Maybe the last question is the difference, the variation of the numbers. Is it Tobias? We said, 71. We said 57 of the overall, all the students, out of the 33%, were not using the contraceptives. Only 42.9% was using contraceptives. All the contraceptives included, the cumulative contraceptives, the pills, the condoms, the injectables, the implants, and all that. No, that is the overall for both gender.
Okay. 49%? There is another slide.
With the 49%. There's no 49%. So we said the male uptake was the highest at 51%. Now when you go by gender, yes, and their counterpart females was 49%.
Okay, and those who did not take, how many?
We had 10%. We had 10% non-response to the study. Yes.
I think that is very good, Kubai. You've dealt with various issues that have been raised by the audience. We want again to appreciate you for the presentation. Please join me in appreciating Kubai. Yes. And with that presentation now, we have looked at our schedule and we've come to the end of all the presentations that were lined up this afternoon. First, I really want again to thank all of you for sitting in to listen to these presentations, our communication team for making it possible for us to share this presentation even with those persons who are not physically with us. For all the presenters who have presented this afternoon, we say thank you very much for finding time to share with us your data. You're grateful for your time. And finally, as I indicated, I'm very grateful to the rapporteurs who have been taking notes of the various information that has been coming from the presentation. So thank you very much, Dr. Kapigen and everybody else who was here. Now, as we come to the close of this presentation, we have got other groups that are in various other theaters. And it would be good, and I ask you kindly, we join everybody else in Theater 4 so that we can have our closing session to this conference. Overall, I believe all of us have benefited very much from the conference. We've made friends, we've created networks, and we've come up with or gotten some new information that was not with us before the conference. At the same time, I think we have new avenues through which we can come up with collaborative ventures in research. So for me is to thank you very much. The entire day we've been together with you. Some have been coming, others going. I thank you, all of you, for giving us your time to listen to us. Thank you. So let us join our colleagues in Theater 4 for the official closing of this international conference. Thank you. Thank you, Kubai, for sitting in to me, for me when I wasn't there. Thank you.